All right, we're going to begin things so we stay on time and are respectful of our time together here this morning. Thank y'all for coming out. So we'll do a brief introduction of you. Again, just welcome out to the CDAD. It's our 11th annual Community Drug Awareness Day. Remember, it doesn't matter how we gather, but that we do gather. And now that we're doing it virtually, sometimes it could be better. Sometimes it could be easier to take notes and pay attention. So we're glad you're joining us. My name is Johnny Bravo Holloway. I'm serving as our MC, I think, for the 8th or 9th year. Love doing it as a second-generation Houstonian. This is my community, so I care for it as much as you do. So making sure that we have great tools, great stats, great information, with well over 400 people joining us today from prevention, treatment, and recovery, and the law enforcement community. Thank you for joining us today. So, ladies and gentlemen, we have a wonderful set of speakers coming up next. Our next set of speakers are going to be providing a national update on COVID-19 and behavioral health. So we have three speakers that are going to be joining us, and they're all three right there. There we go. So, ladies, how are y'all doing this morning? Thumbs up. Are we good before I do the introductions? Wonderful. So this will be fun and interesting in a virtual setting. So first off, the first introduction is going to go to Captain Karen Herod. So Captain serves as the SAMHSA Regional Administrator for HHS Region 6 and an officer for the United Public Health Services Corps. In her role as the Region 4 Administrator, she supports the states of Arkansas, Louisiana, New Mexico, Oklahoma, Texas, and 68 federally recognized tribes. Captain Karen also provides technical assistance and promotes program development and policy innovation. Done a lot of great work. Also, in addition to providing leadership as the chair for the IHS National Zero Suicide Advisory Committee, she served as a member of the National Suicide Crisis Policy Committee, working to establish the first IHS National Suicide Care Policy. That's one of our first speakers. That's going to be Captain Karen Herod. And then Julie Lothrop. So Julie serves as the acting regional director and executive officer in the Office of Intergovernmental and External Affairs, IEA, for the Region 6 Office of the U.S. Department of Health and Human Services. She has a really extensive background. Also is over the 5-state region, including Arkansas, Louisiana, New Mexico, Oklahoma, Texas, and those 68 federally recognized tribes. So great work doing that as well. Ms. Lothrop began her federal career as an intergovernmental affairs specialist for the Office of the Regional Director of the U.S. Department of Health and Human Services. She has a Bachelor of Arts degree in Sociology and Master of Science in Gerontology from Baylor University. There you go, up in Waco. She also served as the Education Corps Director and Principal Investigator on a National Institutes of Health grant to develop the healthcare professional materials for National Alzheimer's Disease Research Center. And she's from Little Rock, Arkansas. That's Julie Lothrop. And then our third speaker that we're going to see here in the next hour or so is going to be Tracy Murray. Tracy has a lot of designations. Has been registered nurse for over 10 years, earned a Bachelor of Science and Nursing degree with honors from TCU, Texas Christian University, just up north, as a commissioned officer. She's also been active in the Black Commissioned Officer Advisory Group and Commissioned Officers Association. So ladies, thank you so much. It's going to be Tracy, Karen, and Julia. Ladies, take it away and share some national updates on COVID-19 and behavioral health. Thank you for joining us this morning.
Thank you. Well, I think I'm going to go first. I'm Julia Lothrop, and so I wanted to, let me just share my screen. Can everybody hear me? Okay, great. Let me just share my screen. Can everybody see that?
We see your smiling face. We need.
Oh dear. Okay.
It's okay.
Just a
We'll
second.
help you through it.
All right. Just a second. Share screen. Okay, maybe this will work. Now, can you see the screen?
Yes.
The slides? Okay, so.
If only we could just tell the computer, here's what I want to do. I don't want to click around.
So now.
There we go. Good job.
Okay, sorry about that. All right, sorry to take up some time. So anyway, I just wanted to thank everyone for the invitation to join you today. And you all can hear me, right? Okay. So as you know, September is National Recovery Month, where we celebrate those in recovery and educate all Americans that behavioral health is essential to overall health, that prevention works, treatment is effective, and people can and do recover. This year's theme, Join the Voices for Recovery, Celebrating Connections, reflects the spirit of the Houston-Harris County Office of Drug Policy, where each and every day your impressive coalition of partners assists individuals with substance use and mental health issues by connecting them and helping them navigate systems of care on their journey to recovery. Thank you for your advocacy on behalf of those facing behavioral and substance use challenges. You are to be commended for your initiative, resilience, and collaborative activities like the Houston Crackdown Network. We appreciate all that you do every day. So as you see from this map, HHS has 10 regions. I'm with Region 6, as are my colleagues, and we cover a 5-state region: Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. We also work with the 68 tribes, as was mentioned earlier. So you've likely seen our Secretary, Alex Azar, on TV during the coronavirus task force meetings. He's been at the forefront of fighting COVID-19. When he became secretary, he set ambitious goals for HHS. So HHS is committed to ending the crisis of opioid addiction and overdose in America. HHS is working to improve the availability and affordability of health insurance. We are determined to lower the cost of prescription drugs for all Americans. HHS is working to transform our healthcare system into one that pays for value. And we're working also to end HIV by 2030. Houston and Harris County have battled COVID-19 in a heroic way. I want to recognize County Judges Hidalgo, Keogh, and George, Houston Mayor Sylvester Turner, and other elected officials, along with the health departments, healthcare providers, and frontline workers for all that you have done to turn the tide. The daily counts of new cases of COVID-19 have been slowing recently in Region 6, and we still have hotspots. With states, local governments, and healthcare partners, HHS has been working to defeat the virus. We continue to send COVID-19 response assistance field teams or crisis officers to work with local partners to support and collaborate on strategies to address COVID-19 emerging trends. So 9 teams have supported Texas, including 3 in Harris County. As of Monday, 103 million COVID-19 tests have been completed, and turnaround times are much shorter. Federal surge testing has been established in 10 states and 20 localities to date, including Harris County and Houston. And we continue to add surge testing locations. Retail and pharmacy partners in more than 1,300 locations in all 50 states and DC have conducted over 2.2 million tests to date. 94% of the 13,000 HRSA-funded federally qualified health center sites offer COVID-19 testing. Recently, HHS awarded $760 million contract to Abbott for delivery of 150 million rapid Abbott Binex Now COVID-19 antigen card point-of-care diagnostic tests. That's a mouthful. But we are expanding testing with these machines. The Abbott Binex Now tests do not require instrumentation, and they'll deliver COVID-19 test results in 15 minutes or less. The test uses nasal swabs, and it's simple to use, inexpensive, and can be easily employed in certain non-clinical environments like schools, colleges, workplaces, and those places can operate through a CLIA certificate. So, and it also comes with a companion phone app, so it allows for instantaneous reporting. And as I understand it, the test cost $5 as opposed to $100. HHS acquired and works weekly with states to distribute remdesivir medication to hospitals, the life-saving drug. We encourage donations for convalescent plasma. So if you know someone who has recovered from COVID-19, please encourage them to donate plasma. Vaccines are in development. In fact, 4 are in phase 3 clinical trials, and volunteers are needed for clinical trials. So you can sign up at hhs.gov. There's a link there where you can sign up to volunteer. Recently, HHS and the Department of Defense issued 2 documents outlining the administration's strategy to deliver safe and effective COVID-19 vaccine doses to the American people as quickly and reliably as possible. The documents provide a strategic distribution overview, along with an interim playbook for state, tribal, territorial, and local public health programs and their partners on how to plan and operationalize a vaccination response to COVID-19 within their respective jurisdictions. So HHS is working with states on these plans as to how they will be distributing COVID-19 vaccine when it is available for distribution. Yesterday, the CDC announced $200 million of CARES Act funds to 64 jurisdictions through existing immunization and vaccine for children cooperative agreements. These funds, along with previous support that CDC has provided, will help states prepare for COVID vaccine. Additionally, HHS extended coverage under the Public Readiness and Emergency Preparedness Act, the PrEP Act, to license healthcare practitioners to prescribe or administer point-of-care COVID-19 tests, and to pharmacists to administer vaccines to individuals aged 3 through 18 years, subject to certain requirements. And COVID-19 isn't the only infectious disease that we face. Seasonal influenza remains a significant threat to our health every fall and winter, and we believe that threat may be exacerbated by COVID-19. Ensuring that as many Americans as possible receive flu vaccines before the upcoming flu season will be more important than ever. A 2018 study showed that from 2012 to 2015, flu vaccination among adults reduced the risk of being admitted to an ICU unit with flu by 82%. Getting vaccinated for flu can save lives and conserve healthcare resources for COVID-19 patients and others struggling with severe illness. Yet less than half of the US population gets vaccinated for flu each year. The CARES Act includes resources for services and supports that benefit people with mental health conditions. Our next speakers will discuss this in detail. Medicaid provides a temporary 6.2 increase in federal matching rates for Medicaid programs. So that's a bonus as far as COVID goes. The states are also required to cover COVID-19 testing in Medicaid and Children's Health Insurance Program without cost sharing. This includes for uninsured individuals as well. Additionally, Medicare and Medicare Advantage programs cover COVID-19 testing without cost sharing. Medicare Part D plans are required to provide up to a 90-day supply of prescription medication upon request during the COVID-19 emergency period. And Medicare telehealth was expanded, allowing people to receive telehealth services in their home from a broader range of providers. Through the CARES Act and the Paycheck Protection Program and Healthcare Enhancement Act, the federal government has allocated $175 billion in payments to be distributed through the Provider Relief Fund. Qualified providers of healthcare services and support may receive payments of healthcare related expenses or lost revenue due to COVID-19. Separately, the COVID-19 uninsured program reimburses providers for testing and treating uninsured individuals with COVID-19. These distributions do not need to be repaid to the U.S. government, assuming providers comply with the terms and conditions. Any provider of the healthcare services included in this eligibility for these provider relief funds are behavioral health services, case management, community-based social support, home-based social support, residential facilities, and substance use facilities. So as Dr. McCurdy had mentioned, during COVID-19, it's very stressful. Some people are struggling financially. Some may be juggling homeschooling with trying to work. Many have lost loved ones or have themselves become seriously ill. Social distancing can lead to loneliness, isolation, and many are anxious about the future, desiring things to return to normal. Chronic exposure to stress and the absence of control, as you know, can lead to feelings of helplessness and anxiety in response to circumstances over which we have little or no control. Add hurricanes and tropical storms to that, and you can only, imagine the stress that many in Houston and Louisiana are experiencing. An August 14th Morbidity and Mortality Weekly Report, MMWR study, found that 40% of US adults reported struggling with mental health or substance use in June this year. The pandemic has contributed to increased rates of depressed mood, suicide, and increased substance use. Suicidal ideation was also elevated. That is why the work you all are doing to address behavioral health and substance use during this pandemic is so vital. We are all learning from this pandemic. As with any adversity, we will emerge stronger, healthier, and better connected communities. Thank you for your time today. I've listed some resources for you, the CDC website, and also the HHS website where you can get more information about doing. Thank you.
All right, good morning. Could you give me a thumbs up, other panelists, if you can hear and see the slides okay? All right, great. So as mentioned in the introductions, I'm Lieutenant Commander Tracy Murray, and I work with Captain Karen Hurd. We're in the SAMHSA Region 6 office, and we'll be sharing a bit about our updates as well as our agency's response to COVID. As our acting regional director mentioned for SAMHSA, these are our top 4 main principles here. Our agency's mission is to reduce the impact of substance use and mental illness on America's communities. And our guiding principles are that behavioral health is essential to health. It's just as important as physical health. Also, that prevention works. It can be hard to quantify the things that you prevent from happening, but prevention is a very worthy cause. Also, that treatment is effective. So at SAMHSA, we do work hard to ensure that evidence-based practices are shared. Looks like there's a trouble with seeing. Okay. And then finally, one of our main points is that people can and do recover. On this slide, you'll see a more detailed look at our principles and priorities, and I'll just highlight those priorities for you. Certainly, as you know, we're working hard to combat the opioid crisis in our region, but we also spend time looking at issues related to serious mental illness as well as serious emotional disturbances. And we also look at broader substance abuse issues. So not just opioids, but we also spend time discussing issues related to stimulants and heroin as well as cocaine. And then also we work at strengthening provider education and training. So much like the presentation that we're sharing today and with our other regional partners. I want to take a moment to just discuss stigma. That's one of our regional goals and initiatives is to share some anti-stigma related messaging and just to address the impact of stigma on behavioral health treatment and care. So defining stigma is a set of negative and often unfair beliefs. Can also be considered a mark of disgrace that sets a person apart. And it can be something that takes away from one's character or reputation. So stigma related to mental health is, for example, most recently, you may have heard that Dallas Cowboys quarterback Dak Prescott shared the impact of his brother's suicide, as well as the impact of all the stress and anxiety from the pandemic and how that was weighing on him. And he felt a bit depressed. Instead of support of that, sports commentator actually said that was a sign of weakness for Dak Prescott to share that information. That's what we mean by stigma. It takes away from his character, that somehow him sharing his struggle would be seen as a weakness. Instead, that's a sign of empowerment. For him being able to speak about it and share his own experience, what that does for someone else to know they're not alone in their behavioral health struggle. They're not alone in whatever anxiety or depression they're dealing with during the pandemic or any other situation. So we want to work to prevent and reduce that type of stigmatization around behavioral health. And we all have a role to play in that. It's not just healthcare, behavioral health providers, policymakers play a role, the criminal justice system, our education in early elementary, high school, universities. everyone has a role to play in creating an environment where it's safe and encouraging and supported to be able to say that you are struggling with something, that you need help from those around you. Regarding the CARES Act funding during the pandemic, SAMHSA received quite a bit of dollars that we've shared and funded several programs. So we funded about $425 million to increase access to mental health services, another $40 million in emergency response for suicide prevention, $7 million again for the Suicide Prevention Lifeline Crisis Center, and then $110 million in emergency grants, again, all in efforts to extend or expand care. Some of SAMHSA's guidance specific to the COVID pandemic has been how to safely administer naloxone, which is a drug that can be used to reduce or reverse opioid-related overdoses. We also have some waivers and provisions for 42 CFR Part 2, which I'll speak more about later. And then exceptions for opioid treatment programs, whereas a person would normally have to go to the methadone clinic on a daily basis to receive their opioid treatments, their medications. Instead, we've made exceptions so that a person can do a 28-day supply of take-home doses, which is much more convenient and allows that person to stay safe at home and still receive the valuable and important medication that they need. At SAMHSA, we have what we call our TTCs, our Technology Transfer Centers, and we have the ATTC, which is related to addiction, the MHTTC, they focus on mental health issues, and the PTTC, which focuses on prevention. Throughout the pandemic response, these three TTCs have hosted over 500 events related to the pandemic, again, related to addiction, mental health, and prevention needs. And they've reached and served over 87,000 participants through their work. And so we've included the links here that you could access all of their resources should you desire to do so. Regarding the 42 CFR Part 2, so SAMHSA has the Center of Excellence for Protected Health Information, our COE PHI. They work under the name of Focus PHI as well. And their main goal is to improve understanding and application of privacy laws and regulations. So things you may be familiar with like HIPAA or FERPA, but also 42 CFR Part 2. And these are all related to improving the care for treatment regarding substance use disorders and mental illness. More specifically, the provisions that were made in response to the pandemic were to break down barriers to sharing patient information during the pandemic. And so looking at how do we eliminate treatment silos between behavioral health providers and other healthcare providers so that there can be more integrated care, that sharing of information for holistic care of patients. And so that was part of the revisions to the 42 CFR Part 2. If you're interested in learning more about that, definitely encourage you to use the link on the previous slide to get some more training from our Center of Excellence that focuses solely on that training right now. So I'll turn it over to Captain Carrie Hurd to move forward with some of our most recent data.
Oh, good morning. Thank you for having us this morning and giving us the opportunity to share what's going on at SAMHSA, or the Substance Abuse Mental Health Services Administration. Also, thank you to my colleagues, Julia and Tracy, for sharing some very important information. So I'm going to shift gears just a little bit and share with you some information that was just published last week on a survey that SAMHSA does every year called the National Survey of Drug Use and Health. So this survey surveys folks in all 50 states, including District of Columbia. It looks at people that are 18 years and older and asks them questions about their mental health and substance use. It includes homeless that are sheltered, but is limited a little bit because it doesn't include homeless that are unsheltered, as well as it doesn't include active duty military. So that's a little bit of the limitations. Each year, about 67,500 people are surveyed. And this information really gives us the data that SAMHSA needs to see whether our programs, our resources are making an impact, and then also if we need to place resources in other areas. So I'm going to share just really some high-level information, and then I'm going to share with you a link where you can maybe take a deeper dive. Also, this information is also broken down in some different ways. So it's broken down to states and counties, also to some ethnicities. And so if you check back on our website in a few months, you're going to be able to see this information broken down to be more specific to your area. So I'm going to go through just really kind of like a high level of what we saw in our kind of movement, particularly around mental illness and substance use disorder. So in 2019, you can see on this slide that about 19.3 million people age 18 or older in the US had a substance use disorder. On the mental health side, about 51.5 million age 18 or older had a mental illness. And about 1 in 4 of those folks with mental illness had a severe mental illness. And that's a mental illness that really interfered with their day-to-day functioning. If you look over on the substance abuse side, you see that about 3 in 4 of those folks with substance use disorder had alcohol use disorder. About 2 in 5 struggled with illicit drugs, and about 1 in 9 struggled with illicit drugs and alcohol. Now, some work is done around co-occurring disorders, and that is a person that has both mental illness and a substance use disorder. We saw that there were about 9.5 million people that could be diagnosed with both a mental illness and a substance use disorder. What alarms us about this is that we see if you look at everyone that either had a mental illness or a substance use disorder in the US, we saw about a 5.9% increase over 2018, and much of that could be related to increase in mental illness. So we have some concern about this increase. Also be aware, that this data was collected in 2019, which is really kind of pre-COVID as well. And so we have seen some research and some information coming in that there's going to be some significant, or has been significant, impacts on mental health and substance use due to COVID. So I do have concern about post-COVID data as well, that we may see an increase. Go ahead and go to the next slide. So just looking at the progress on the opioid epidemic and prescription pain reliever misuse, we see about 10.1 million people with opioid misuse, or about 3.7% of the population. So we saw a modest decline overall for each opioid category except prescribed fentanyl. So if we look, we can say in the US that we have around 745,000 heroin users. We have about 9.7 million folks that misuse prescription pain relievers, which is a considerable amount of our opioid misusers. When we break those down by class, we see about 5 million hydrocodone, 3.2 million oxycodone, and about 269,000 prescription fentanyl. Go ahead and go to the next slide. So in summary, and this is just really kind of high level summary of what we saw 2019 versus 2018, we did see an increase in opioid use disorder from about 2 million to about 1.6 million. That's really good news because for many years, we saw this steadily track up. Efforts to increase access to medication-assisted treatment, psychosocial and community recovery supports, we think have had a positive effect. SAMHSA's put a lot of dollars into states and tribes with our state opioid response grants and our tribal opioid response grants. Those are like that little bit over 1 billion per year that have gone specifically to states. Among those aged 12 plus, opioid misuse decreased significantly as well from 2017. Pain reliever misuse has decreased significantly from 2018 for the 12 to 17 year of age, and it continues to trend downward for 18 to 25. So we're pleased to see that. We've also seen heroin initiation decrease significantly with about a 57% decline from 2018. Also for the 18 to 25 as well, a decrease. One of the things that is very concerning to us, though, is that despite gains, opioid overdose deaths increased in 2019 by about 4.6%. And we believe that this has to do with the really potent illicit synthetic opioids that have come to the market. And one of the things that's very concerning to me related to COVID is that we've seen a disruption in supply in a lot of areas. And so novel suppliers coming into the area. And then we've also seen methamphetamine with fentanyl as kind of trying to amp up the product in some areas. And we believe that this has been one of the drivers that has led to the increase in overdoses. So I just wanted to share as well that, we have really tried to increase medication-assisted treatment for methadone, for buprenorphine, or Suboxone, and also for naltrexone. But we still continue to see buprenorphine being reported as people acknowledge misuse of the medication. We think that in some cases, this is a person with opioid use disorder attempting kind of like to self-medicate their own addiction. And so we really want to make sure that we have treatment resources available so that people can get into treatment and be able to use the buprenorphine as prescribed and be able to move forward in the recovery process. Also, we're really interested in development of buprenorphine products that are maybe not as easily diverted, such as injections and other kind of longer lasting buprenorphine products. Okay, go ahead and go to the next slide. So when we look just at a really high level summary of the mental health and co-occurring issues, we see that serious mental illness significantly increased in adults 18 to 49. And just again, be aware, this is actually pre-COVID data. Major depressive disorder significantly increased in all age groups. Suicidal thoughts and behaviors, we saw some significant increases. Post-COVID, for our disaster distress behavioral helpline that SAMHSA funds, at some points we saw a 1,000% increase in calls in the March, April range. And a lot of those calls had to do with depression and anxiety related to the coronavirus, unfortunately. Also, our concern for adolescents that we've seen significant rates of increase in mental illness and substance use. Adults aged 18 to 49, significant increases in mental disorders. And despite some modest gains, we still see a large gap in treatment. So those that are in treatment may not be getting the treatment that they need for their co-occurring disorders. And most with current co-occurring disorders, so those with both a mental illness and a substance use disorder, might get treatment for one disorder or no treatment at all. So in our country, we still see a significant treatment gap and continue to work on addressing that gap. Go ahead and go to the next slide. So some progress, but some concerns as well. So we really need to continue to address the ongoing opioid epidemic. I also want to honor what I heard related on Dr. McCurdy's presentation about still the concern with stimulants. With the state opioid response grants, for the first few years, those grants could only be used on opioids, but it was heard from our states that stimulants were an issue as well, and so that funding can also be used on stimulants if states see the need for that. Also, in June 2020, SAMHSA developed a new product for outlining treatment of stimulant use disorder. If you look on our SAMHSA website, you can take a look at that if you have interest. Now, we knew with legalization, both medical and recreational, of marijuana across several states, that we probably, would see an uptick in marijuana use. And so we saw that in our 26 plus. Unfortunately, we're also seeing that in our adolescents. LSD is making a comeback as well, and a rising year over year serious mental illness age 18 to 49. So also, LSD use significantly increased in adolescents, and there's a rising year over year serious mental illness in adults 18 to 49. Polysubstance use, and I heard that in Dr. McCurdy's presentation, is definitely something that's pervasive among substance users. When I first started this work 20 years ago, most folks that came to the treatment facility that I worked at had alcohol use disorder. And if they had alcohol use disorder, then there was occasional use of possibly stimulants or other medications. Now we see that there is very, very much increased polysubstance abuse, and there's really kind of a need to look at this globally. Additionally, severe mental illness is a risk factor for hazardous alcohol use and illicit substance abuse. So they're all interconnected, and so as Dr. McCurdy was sharing, we can't just silo our dollars to treat one substance. We have to look at this globally across kind of like the continuum and be able to spend our dollars wisely to address the totality of substance use versus just like one substance. Go ahead and go to the next slide. So this is what I promised. So this is our Assistant Secretary of Mental Health and Substance Use, Dr. Eleanor McCants-Katz. She is the first ever Assistant Secretary for Mental Health and Substance Use Disorder and the Director of SAMHSA. So she has put together a recorded presentation. Get your popcorn. It's about 1 hour and 30 minutes long, but it's really good and really goes into depth of all of this data. There's also the PowerPoint for all of these slides is also included, and these slides can be used in your communities to share kind of the picture that we have from the national survey. Go ahead and go to the next slide. So this is a resource that I wanted to make sure that we highlighted. It's the Provider Clinical Support System. So this is SAMHSA's vehicle to get physicians, nurse practitioners, other clinicians trained to not only prescribe medication-assisted treatment with one of the, it's particular to buprenorphine for this because it's the vehicle to get the data waiver to be able to prescribe buprenorphine. But it's not just limited to that. It's really a huge kind of library of trainings to increase the skills and knowledge of people that treat not only opioid use disorder, but substance use disorder. Everything is free, and a lot of the trainings are also tied to CEUs or CMEs. So I would encourage you to log on to pcssnow.org and take a look at the offerings there and see if there's something that you may have interest in. Go ahead and go to the next slide. So Lieutenant Commander Murray talked about our Technology Transfer Center network, but I just want to share just a little bit more about it. So each HHS region, and so the Region 6, which is that Arkansas, Louisiana, Oklahoma, Texas, and New Mexico, has an addiction technology transfer center, a mental health technology transfer center, and a prevention technology transfer center. For Region 6, the ATTC and the MHTTC, and it's called the South-Southwest ATTC, MHTTC, PTTC. The ATTC and the MHTTC are out of the University of Texas at Austin. And then the Prevention Technology Transfer Center is out of the University of Oklahoma at Norman. The whole goal of these centers is to get out evidence-based training and treatment to clinicians and allow those clinicians to be able to implement that knowledge to fidelity in our communities. The ATTs and the MHTTCs played a huge part when many people in our region had to pivot to telehealth due to COVID. And literally, we had people that were calling our office saying, our system has been told that we shut down on Friday and Monday we start telehealth, and we've never done telehealth before. And so we were able to partner with the National Center of Excellence for Telehealth and do trainings related to that. So I really would encourage you. Also, we're not just limited to our regional TTCs. There's this huge network of really big brains that are part of it. And we're lucky that we can be able to benefit from all of them. So when you have some time, take a look. Go ahead and go to the next slide. Also, our opioid response network. So this is funded through our state opioid response dollars. So this is really a first for SAMHSA. Previously, a lot of our technical assistance at SAMHSA was limited to our grantees. This is an opportunity that is available for anyone. So if you go to the opioidresponsenetwork.org and you have an interest in anything really that has to do with opioid prevention, treatment, or recovery, you can go in and hit submit requests on the button on the top of the landing page. Type 2 or 3 sentences about what you have interest in, and someone will call you within a couple of days and help connect you to a panel of regional experts to be able to assist you. The smallest request that I have heard of so far is a grandma in New York that was caring, unfortunately, for her grandchildren because her son had died of an opioid overdose. She recognized in her neighborhood that there were other grandparents that were in the same boat, and so she wanted to figure out how to start a help group for those grandparents. One of the largest requests that we had in our region was Charities Hospital in New Orleans. They wanted to have assistance in getting all of their residents waiver to prescribe medication-assisted treatment and to be able to prescribe for folks that were presenting to their ER and then connect them to care through peer recovery support. So that was a huge one for ours. So if you have interest, go to that page and take a look and take advantage of these totally free resources that are available to you. Go ahead and go to the next slide. So this is just kind of like a compendium of resources that SAMHSA has. Our tip 63 for opioid use disorder treatment is highlighted, as well as our national helpline. One thing that I wanted to share that I think is really an amazing thing that has happened. So our suicide prevention lifeline, 1-800-273-TALK, it has gone through all the hoops and received FCC approval. And so most likely next year, that number will transition to 988. So excited for that. So that will be like a national 988 suicide prevention helpline. Also with the suicide prevention helpline, there's a special link to the veterans suicide prevention line. And so this is really kind of an amazing thing that's happened, and I'm so excited about it. There's also an opioid overdose prevention toolkit that's available. So just really amazing amount of resources that are available on the SAMHSA website if you just get on and take some time to peruse. Go ahead and go to the next slide. So I wanted to also call attention to the funding opportunities that are available through SAMHSA. You can get signed up to receive notification of new opportunities on our grants landing page, and that is the link to do it. Go ahead and go to the next slide. And this is the contact information for myself and Lieutenant Commander Murray. Our role in the region is really to represent, not only to represent SAMHSA headquarters and the Assistant Secretary in the region, but it's also to represent the region to our headquarters and the Assistant Secretary. We really need to hear from you. If you're having issues, if you're having concerns, if you have ideas that we might be able to share with our leadership, we want to hear. So this is our phone number and our email, and we are always open to hearing from our stakeholders, and hopeful that you will feel comfortable reaching out to us if you have need. So with that, I will close, and I think we have some time for questions.
So if you have a question, go down at the bottom, you'll see chat, go to Q&A, and that's where we're gonna ask the question, not in the chat. Go over to the Q&A. No, the dog is not asking questions. That's not appropriate.
Oh my gosh.
What's the name of the puppy? Gotta address it, we've already seen it.
Yeah, you guys, COVID is hard, right?
It is,
Working
real
from
life.
home is hard. I tell you, one of the things though that I have really loved is the grace that I see from people. And I also love to be able sometimes to see their families, right? I mean, like we're all like real people living through this, trying to figure it out. So
What's the name of your puppy?
Her name is Betty. Yes.
Betty. What kind of puppy is it?
She's a little terrier mix.
All right.
So,
well, you know, I think it's important to address it. You pushed through, you prevailed well. I don't know if it was a package that showed up or not, but really good job. That was hard. So good job.
Yes, showed up, and they are not her friends.
So one of the questions Susie has is there research on medically treated stimulant use disorder? Meth is a huge problem here in Houston, of course. Is there research on medically treated stimulant use disorder?
So yes, I would encourage folks to go to our SAMHSA website. I may also be able to share that link on the new publication that we have specific to treatment of stimulants. One thing that I can say though is that treatments have not been as progressive. Like over the years, you know, the different kinds of evidence-based treatments are small in number, you know, for stimulants. And so I'm really hopeful that our research broadens that availability to treat stimulants. Like we don't have medications, right, to treat stimulant use disorder as we might have for opioid use disorder. But I'll try to share that link on the chat so that people are able to find that.
Okay. Let's see here. Looks like Kristen has a question for Julia. It would be many people that she knows. So she says, many people that I know have stated that they likely will not get the COVID vaccine because of one of the government, that the government has backed the effects and changes. What are your thoughts about this? How should someone who is pro-vaccination respond to people that raise this argument about the COVID vaccine? What are your thoughts on that? And that is for Julia.
So yeah, I saw that in the Q&A. So one place that you can go to get some information would be the NIH director's blog. But what I've found is that, you know, the mRNA vaccines are relatively new. So one thing you can mention is that the mRNA vaccines work by introducing a molecule into the body that instructs the cells to build a disease-specific antigen. And that antigen is then recognized by the immune system to produce antibodies. So I think of it sort of like if you have allergy shots, they're going to introduce things that you're allergic to in order to build an immune response. And that's sort of what this is doing. So it's not going to alter your DNA. And what this is doing is they're not going to use part of the virus like some traditional vaccines in that particular shot. They're going to introduce mRNA, and then that's going to produce an antibody response in your system. And so that's the difference. So I hope that helps. So
very thorough. I like that. Let's see here. So Shelley, we do have a few minutes. Let's check and make sure time frame. When I say a few minutes, we mean literally a few minutes. So put those questions down in the Q&A. We're going to review them and see if we can answer some. Latravia, you are paying attention. I don't know if we can give you extra credit or not, but if we could, that'd be great. A lot of good questions here. Shelley Garza Clark says, we've seen a dramatic increase in vaping marijuana in schools. Schools are disciplining students with exclusionary practices. Is there an effective model that you've seen used in schools for working with students to engage in drug use? Good question, Shelley. That's for any of y'all. Or the puppy. Where's Betty? Bring Betty back. You got to bring Betty back. Yeah. So the question from Shelley was, we've seen a dramatic increase in vaping marijuana in schools, and schools are disciplining students. Is there an effective model you've seen used in schools for working with students to engage in drug use? Any of y'all answer?
Yes, so I know there are some effective models. I would encourage you to visit the Southwest Prevention Technology Transfer Center website that was shared in the slides. There are some really good links to curriculums that I think might be helpful to you.
Okay. Let's see here. We'll do one or two more questions. Let's see. So Latravia's question is the Substance Abuse and Mental Health Administration, SAMHSA, leading research on harm reduction services for OUD and other disorders. Is it the leading research on harm reduction services?
Yes, so SAMHSA would really not be in the lead on that particular research. NIDA is doing some research around harm reduction. There has been some movement for some SAMHSA grant dollars to be used on some specific kinds of harm reduction. And then also our HHS Region 6 Office of the Assistant Secretary of Health has been doing some work in the region, particularly around harm reduction. And I have lost the name. Julia, help me with the name for the needle exchange.
Syringe Services Program. That's the name. And so if you go on the website for the Office Assistant Secretary of Health, you can find out some things about syringe services programs that are some supports. We're also in Region 6, we have some of the counties that have some of the highest rates of HIV new infection prevalence. And so due to that fact, we have 2 commissioned officers that have been deployed to our region doing a program called PACE. And so part of their program is to help encourage those kind of like harm reduction behaviors that decrease the transmission of HIV infections and hepatitis C. So, we are doing some work around that. So if you are interested in finding more about that, just reach out to me directly and I'll connect you to those resources for the region.
Okay, let's see here. Well, look at that. We have a words of affirmation person. Susan says, thank you for the explanation of COVID-19 vaccine. Cancel that. Let's see here. All right. Well, I think what we're going to do is we're going to take a brief break. Really, ladies, thank you so much. Y'all were wonderful, and give Betty a paw 5 when you see her.
Thank you. Thank you for the grace that you gave me with that. I really appreciate it.
I love it. I think it's the best. It's the best when our little 2-year-old jumps in my lap or something. I'm like, here it is, real life. So again, Julia, Karen, and Tracy, ladies, great work. Thank y'all so much. Y'all are wonderful. Virtual high fives. Woo, bam, boom. Oh my gosh, almost knocked my computer down. Joking. We'll be back in about 5 or 10 minutes. Go get some water, stretch, do some push-ups, jumping jacks. Don't drive on 45 right now because you're supposed to be watching this. We'll be back in about 5 or 10 minutes. Thanks for coming out. Good job. Thanks, ladies. As you guys are beginning to come back into the auditorium of Zoom and take your seats or stand, just don't stand on 45. That would be weird. We have another great presentation. We're going to be learning a little bit more about the opioid epidemic, which obviously we spend a lot of time on. We've done so for the last couple of years. So we have 2 wonderful speakers that are going to be joining us for the next 45 minutes or so for their allotted time. I do want to remind you of a couple of housekeeping things. For those who would like continuing education credits for TCOL hours, you will be given instructions at the end of the conference today and tomorrow. So if you need those credits, it's mandatory that you stay until the end of the conference. That is regulated and mandated and required by the state of Texas. I also want to thank our sponsors and our volunteers for all of their help and so much more today. So thank you guys so much. So our next speakers that we are going to hear from are going to share a little bit about the opioid epidemic. Dr. Sherry Oniego is currently serving as the Interim Director for Chronic Disease Prevention in the Nutrition and Chronic Disease Division, NCDP. She is also a board-certified family physician with over 15 years of clinical experience in managing and treating chronic diseases as it relates to individual patient care as well as population health. You see, Dr. Oniego also serves as the alternate local health authority assisting the executive director of the Harris County Public Health, a big responsibility, and we appreciate you. She's also earned her doctorate in pharmacology with a research focus on novel compounds targeting HIV-1. She's a member of several professional, social, and community organizations and serves on the board of directors for the Harris County Academy of Family Physicians. That is Dr. Sherry Oniego. And joining her is going to be Dr. Alicia Ann Kowalczyk. I think that's right. Sounds fun. Kowalczyk. She is an associate professor with Baylor College of Medicine's Department of Family and Community Medicine and board certified in both family and addiction medicine. She is medical director of Insight, the screening, brief intervention, and referral to treatment program for the Harris Health System, for which she also runs the Insight Clinic. Current and past grant-funded research and program include increasing treatment awareness. Here, I thought this was really cool in her biography is she has received funding and has published numerous articles in peer-reviewed journals. And in 2016, Dr. Kowalczyk signed off on the first statewide standing order for naloxone in Texas. So I love that. Great job being the first one to sign the statewide standing order. Her passion is for caring for families affected by addiction and educating other healthcare professionals and students about effectively delivering that care. So ladies and gentlemen, sharing about the opioid epidemic, Dr. Sherry Oniego and Dr. Alicia Ann Kowalczyk. Give them a high five. Let's go!
All right, welcome. I'm going to go ahead and share my screen. Is that okay? We're going to tag team this presentation. I'm going to kick us off with kind of a broader overview of the opioid epidemic, kind of how we got to where we are, a little bit about where we are. That I knew we heard from our previous panelist a little bit about where we are from the national perspective. And then Dr. Oniego is going to really detail Harris County's response and some great initiatives that are going on with that. So let me go to share screen. Share. Okay, and there we go. Okay, and I hope everybody's seeing this. I'm going to go to slideshow from beginning. All right, is everybody good? We can see. Is everybody seeing the presentation? Thumbs up, yeah? Okay, so we're gonna go ahead. With my part of the presentation, by the end of it, you should be able to easily describe the etiology, epidemiology of the US opioid epidemic, and then really we'll get into a discussion of the ways to effectively address the opioid epidemic from a community perspective. And so how did we really get here? And so this is a little bit about where we've been, because that can help us inform us of where we might need to go or what might help us get to where we want to be. So pain as a fifth vital sign started to be incorporated into various standards, although not mandated, although there is a perception that there was a joint commission mandate in the late 1990s, early 2000s. And this was in response to a number of studies. I've shared one here of oligoanalgesia or undertreated pain, particularly acute pain in a hospital or emergency center setting. And so this one study looked at patients reporting to this emergency center who were 8 years of age or older. They had a pain score of at least 4 out of the 10-point pain scale. It looked at over 800 patients. The median pain score was 8 out of 10, so pretty severe pain. Just over 80% actually had their pain assessed, but a little over half actually got something for their pain, and it took about an hour and a half, if you did get something for your pain, for that to happen. And 3/4 were discharged, still reporting moderate to severe pain. So that's just one of the studies that kind of really led to this push to more effectively try to address people's pain. On the flip side, what we saw after this push to more effectively address pain, we saw in that same decade, the per milligram person use of prescription opioids in the US increased by over 400%. And we've seen since 2011, overdose become the leading cause of accidental death for those of us 18 to 44. And we now experience more overdoses annually since about 2016-17 than the total US casualties in the Vietnam War. So we really come a long way from back then and not the right direction. So this is another way of looking at that early data. So we see that in the late 90s, early 2000s, we had a fairly low rate. These are opioid-related deaths per 100,000 of us in the US. So it was 1 to 2 per 100,000. By the end of the decade, we had almost quadrupled that. So we were up to almost 5 per 100,000. And we see that corresponding to opioid sales, which is the smaller dashes line here, and also treatment admissions, which is good to see treatment admissions go up too. But again, we didn't quite yet see a huge impact from that in that decade. So again, not a surprise to most of us working in this field. This has been something we've been dealing with since the early 2000s. Here's another way of looking at that data and extrapolated out quite a bit. This is taking us through 2015. If we look into the later half of the 2010 decade, we would see that the opioid deaths continue their exponential rise. Prescribing rates continue to go decrease quite not so quickly. And especially this fentanyl, other synthetic line, starts to really increase and drive those opioid death rates. A couple of things about this slide and why I like to share it. We see that in the in early 2010s, reclassification of hydrocodone products as a Schedule II narcotic from Schedule III. And we also see kind of a growing awareness in the medical community about inappropriate opioid prescribing and modifications of guidelines, which up to then had been, if your patient's in pain, opioids are helpful, and if they are still in pain, give them more opioids. And so we really saw that starting to be really assessed within the medical community, and some brakes put on opioid prescribing. And we see that impact here, some modest decrease in opioid prescribing, which continues. But we don't see that deaths related to opioids have trailed off. In fact, the opposite has happened. And so what we've seen is these folks that have become dependent on opioids and have opiate use disorder, once their supplier of their opioid is no longer their clinician, their physician, they are not just suddenly cured of their opioid use disorder. They are turning to what's more easily acceptable in their community, which has been heroin, and then lagging heroin and coming on the scene kind of in the mid-2010s, we see the introduction of fentanyl. And both increase the risk for opioid overdose. So a little bit more about the synthetics. Why are the synthetics such a big deal right now? Where did they come from? As a lot of things in life, it boils down to economics, most generally. So if heroin is twice as strong as morphine, so this is morphine equivalents, we have the synthetic products. Fentanyl is 100 times as potent as morphine, or 50 times as potent as fentanyl. A lethal dose is 2 milligrams in most people, particularly opioid naive, but even those with pretty significant opioid physical dependence and tolerance. You don't need much more than 2 milligrams of pure fentanyl to overdose. And 2 milligrams would be the equivalent of 2 grains of salt, which is pictured here. So you can see very small amounts. Carfentanil, which we see come through communities periodically, usually doesn't last long in communities because this product really kills its customer, which is not a great business model, is 100,000 times as potent as morphine. It's also known as the elephant tranquilizer. A lethal dose is 20 micrograms, which is actually the size of a snowflake. This is not carfentanil, this is really a snowflake, but it's just to give you some perspective on just how potent these synthetics are. And this is the business plan, if you will, or the business model, and why we're seeing so much more fentanyl in communities. And actually, now with the pandemic, we're seeing at least anecdotally, an increase in the fentanyl availability in our community, and cut into not just opioids or things marketed as opioids, but also, as a prior speaker mentioned, methamphetamine and other street drugs. So for about $1,000 off the internet, you can order your own pill press that cranks out about 5,000 pills an hour. For $250, you can get dye molds off the internet as well to make whatever product you're producing look like OxyContin, Xanax. You pick your substance, what you want to try to sell. For about $100, you can get 25 grams. Remember, lethal dose is 2 milligrams. You can get 25 grams of fentanyl. Again, often off the internet. This had historically been coming primarily from China, and that route, we're now seeing it pour over the southern border as well. You add in, let's round up to about $1,000 worth of other chemicals, again, easily purchased. And for if you make a 1 milligram fentanyl per pill product, you get 25,000 pills out of that about $2,500 investment. You can usually sell these things for $10 a pill on the street, and you have a cool $250,000 gross receipts. And so that is why we're seeing these flood into our community. These are some recovered counterfeit drugs, photos of that courtesy of HPD and Houston Forensic Center. They were graciously shared. This is not Xanax over here on the extreme left, but it sure looks like Xanax. Then we have heroin that was actually found to, a big cake of heroin that was actually found to contain fentanyl. Here's a morphine branded product that is really fentanyl. And this is another hydrocodone branded product that is really fentanyl. This is what one of the pill operations look like. Again, this is courtesy of Stephen Casco, Lieutenant Stephen Casco from HPD. And this was taken, it was a bus off of the Southwest Freeway, I was told, in a storage unit. And so you can see this is the operation, and here's a detail of those actual pill machines. These are, again, allows you to tailor your product to consumer choice. So you can see the different dye molds that are available. These are really, really scary. And so that's a little bit about where we were, how we got to where we are now. And so a little bit about some national data. So again, just to remind everyone, overdose is now the leading cause of death for people under 50 in the US. US overdoses in 2019, and this is from CDC data that was just released in August, is back up to 71,000. And it had dipped a little bit in 2018 from the 2017 peak, which was again around 71,000. So we're back up again. And again, you can see some comparisons. For the first time in modern US history, we're seeing life expectancy decrease for younger generations, and primarily this seems to be driven by overdose deaths. And overdose is now the leading cause of perinatal mortality for women. So again, we're seeing all sectors, age sectors impacted. And every 25 minutes, so during our discussion, at least one, almost two newborns will have been born and diagnosed with neonatal abstinence syndrome in the US. So this is a little bit more about the CDC, from the CDC. Their rapid release vital stats product, and this dropped last week. So this is the 12-month ending provisional number of drug overdose deaths in the country. So this includes all drugs, substances, and you can see we continue to increase. And if you want to look, you can see state by state. And you can see for Texas, we're kind of in the mid-range compared to other states. But we saw an 11.4% increase in predicted cases between February 2019 and February 2020. So we are increasing in Texas as well. We've already seen this slide, I believe, previously, so I won't belabor that. I'll share some other slides from that data set. This was the National Survey on Drug Use and Health from SAMHSA. 2019 data that was again just released this month. And you can see that pain reliever misuse continues to level off quite a bit. Pain reliever use disorder, and as well as new initiates. And we can see the same trend for heroin use disorder, and heroin initiates. And this was actually statistically significant for heroin initiates. So that's really good news. So it's not all bad news. Looking at opioid use disorder and by age categories, we see that very positively, we're seeing a decrease in opiate use disorder in youth and young adults. those 26 and older as well, and then across society. But we're seeing our biggest drops kind of in the younger population, which is good to see. Some treatment gains. So this is also positive, good news. We see for methadone, buprenorphine, and naltrexone, the number of individuals receiving pharmacotherapy, which is considered the gold standard treatment for opiate use disorder now, we are continuing to see increases in people getting treatment. Naltrexone has lagged a bit. We see buprenorphine and methadone have increased, and this is the all types of medication-assisted treatment, or MAT. So some key take-home points. Again, this bigger slide was shared previously, but I'd like to highlight that we are seeing some decreases in opiate use disorder. So I think really our efforts to increase access to MAT, our community and psychosocial recovery supports have really made a big difference here. And but despite that, we're still seeing opioid overdose deaths increase by approximately 4.6%. So again, these synthetics are still getting out there, people are still using them, and it's still of concern. And oftentimes now they're getting the fentanyl in products that they're not even realizing contain an opioid. They're not being marketed as an opioid. And that's particularly dangerous because that can be in someone whose primary substance is methamphetamines, for example. And so their tolerance is going to be lower, and that makes that potent fentanyl that much more lethal. What happens when an epidemic and a pandemic meet? It's definitely not a joke. So what our predictions are is that we would see increased substance use and overdoses due to the stress of the pandemic, between financial, caretaking, and other changes that people are having to adapt to rapidly through this pandemic. The isolation that we're seeing and hearing reports of from the recovery community. I know a lot of recovery meetings, et cetera, have transitioned to Zoom, which is better than nothing. And a lot of us are still experiencing Zoom fatigue. And so I've had some of my patients report, you know, it's just not the same. I really miss just being in the presence of others, and the positive impact that has on my recovery. Changes in substance available, so I spoke briefly about that. Because of the pandemic, the borders have tightened quite a bit. And so it's a lot harder to get kind of bulky heroin across than less bulky fentanyl. And so we are, at least anecdotally, seeing a change in substances available. And then perhaps we would anticipate a decrease in access to care as people lose their jobs and have a concomitant loss of insurance. And also some limitations for new patients. So patients that can't engage in telehealth, for example, they don't have the resources, et cetera. Some very, very preliminary local data from HFD regarding overdose incidents. I'd hope to have the second quarter data out for you by now, but I don't. I just have first quarter, which ran through the very first month or so of the pandemic impacts in Houston. But we did see a 31% increase in overdose incidents that HFD responded to within Houston during that time period. And so we can't really definitively say causation, but we are concerned about that. And then before moving this over to Dr. Onyego, how do we recover and sustain health? We really want to ensure that from the medical community, we're not starting people on opiates and getting them addicted to opiates anymore. And we've been doing okay with that. We can always do better. We know now there's little role for opioids in treating chronic non-cancer pain. We also know, and now there are limits to prescribing opioids for acute pain, that most acute pain syndromes that require an opioid for management, 3 to 7 days is generally adequate, and we want to try to lead people to treatment. We want to prevent overdose fatalities and link people with opiate use disorder to effective evidence-based care. So in order to link them to care, they have to survive any overdose, or we have to prevent them from overdosing in the first place. So we're working hard to distribute naloxone and have it readily available and accessible and increase resources. So I'm not going to go through these because I'm mindful of our time, but they are in the slide set. Pain is very common. People's chronic pain is not going away just because of the opioid epidemic. The guidelines have really evolved. There's several. There's a one page to read would be the CDC guidelines for 2016, page 16 out of 52 pages. Basically, opioids and even non-opioid pharmacologic therapies are not preferred anymore for treating chronic pain. We always want to pair any opioid prescription with a naloxone overdose education and kit. And really, it's about changes in the brain that happen regarding chronic pain. There may not be an acute stimulus anymore, but the brain's kind of set itself up to experience pain continuously. And so what has been shown effective is some non-pharmacological treatments. And everything on this slide has been shown in at least one randomized controlled trial to be as efficacious as an opioid for chronic non-cancer pain. And so I think that's really important for the medical community to hear. There are some regulations around opioid prescribing in Texas that have been driven largely by response to the opioid epidemic. There is a limit to 10 days for new scripts. You must check the PDMP each time you prescribe, and there is the statewide standing order. What does a community response look like? There's a multifaceted approach, and I'm going to turn it over to Dr. Onyego. Thank you.
Well, thank you so much, Dr. Kowalczyk. It's always a pleasure to collaborate and work with you. And I also want to thank the meeting organizers and also our team here at Harris County Public Health for really working so hard on this effort as well. So I'm going to try to share my screen to get the presentation queued up. Please let me know if you can see it. Let's see. Are you all able to see it? Okay, yes, thank you. All right, so just to start off with just an overview of what we'll be talking about with the time that we have. I'm really just going to provide an overview of really what our role is from a public health perspective, a little bit about our health department here at Harris County Public Health, our strategic plan, and also want to talk a little bit more about our funder, the CDC, and their initiative and their approach to overdose data to action, what their goals and what their approach is, and then drill down a little bit more specifically on Harris County's prevention needs and our health department's response activities and goals. And so just to start off with, Harris County, if you all don't know, it's quite large, it's quite diverse. In fact, we're the third largest county with really approaching almost 5 million residents, and it spans well over 1,700 square miles, larger than the state of Rhode Island. So quite vast and diverse in our scale and scope. And so this really just from a geographical standpoint just illustrates our county sort of makeup in a map form. And so when you look at the population growth that we've experienced here in Harris County from 2000 to 2018, it's about a well over 40% increase in population. So really, as I was saying, with well over close to 5 million residents. And you'll see with this yellow area in the middle, we always really describe this county as a donut. And really the yellow area is sort of that interior aspect of the donut representing the city of Houston. And so that's well over 2.2 million residents. But the outer areas, the green, the lighter green, as well as these darker green, are these municipalities that reside outside of the city of Houston, which is well over 2 million residents. So again, this is just really just showing you from a geographical standpoint the large, vast makeup of our diverse county. And so when we talk a little bit more about public health, we really look at it as a way to collectively ensure that people are healthy in the conditions where they live, where they learn, where they work, and they worship, and they play. But we oftentimes have an illustration that we use to describe this. You've heard traditionally about the clinical prevention, and that's one of the buckets where we traditionally look at the healthcare aspect of health. The traditional four walls, those are your hospitals, your clinics. And then that's really where the evidence-based treatments and services actually happen. But when you look at that second bucket, that's really more of the clinical, the innovative clinical prevention, and that's really kind of merging outside of those traditional areas and providing services. And then where you find public health really is in this third bucket, where we look at population or community-wide prevention activities. And that's where we really look at implementing interventions that reach entire communities or entire populations. And again, we really, from a public health perspective, we really look at those social determinants of health and really looking at opportunities to really impact individuals that are really addressing the health needs of individuals where they live, where they learn, where they work, where they worship, and where they play. These are our cornerstone values, and we really focus on innovation, education, engagement, and equity. And so when we look at what are our strategic plans and our priority areas, just as it relates to substance use prevention, more specifically the opioid epidemic, we're looking specifically at engagement of the general public. We're looking at opportunities to improve surveillance, expand harm reduction strategies, and also combating stigma. The CDC was released in 2018 a 3-year cooperative agreement, and this was really focused on obtaining and strengthening surveillance data through traditional as well as non-traditional sources. And the data is utilized to be able to drive and inform prevention activities throughout the community. This map illustrates the recipients of the funding that the CDC has released. And you'll see in the darker purple areas, these are all of the states that received funding. And in the lighter lavender areas, you'll see where some states as well as city and county entities have also received funding. But you'll see here in Texas, we're the only jurisdiction for the county that has received this funding to do this specific work. And we're not doing this alone. We certainly have a number of partners, and then we'll be able to talk a little bit more about that. But just wanted to talk a little bit more about the goals that CDC has as it relates to opioid harms and overdoses. Specifically, the CDC is focused on using the data to monitor trends and direct that information to drive prevention activities. Although this is specific for opioids, the CDC is certainly aware that each jurisdiction, just like I illustrated in the previous map, all of those jurisdictions are so unique and they're so different, and we all have emerging trends. And as the speakers that you've heard, even for this conference, have talked about our emerging trends in our community, that they really rely on not just one substance, but polysubstances, multiple things throughout our community. And so we certainly want to use this as an opportunity to, ensure that that information is resonated with the goals for the CDC. So we're strengthening state partnerships as well as local partnerships, as well as other tribal capacities as it relates to this, as it relates to OD2A. We're also, CDC is also very focused on us working with providers, health systems, payers to reduce unsafe exposure to opioids and also to treat addiction. The CDC is also very much so focused on public safety, first responders, looking at community-based partners to identify overdose threats, reverse overdoses, and link people to effective treatment to reduce harms associated with illicit opioids. And lastly, the CDC is certainly really focused on, more importantly, increasing public awareness about the risk of opioids. I want to pause here because I want to make sure that that you all can see the slides. And I want to I changed my mode to presentation to speaker mode. Are you all able to see the slides? Okay. So then I'll just also wanted to illustrate that we focus on the 3 L's when we're looking at, when we're approaching this crisis. We're looking at the opportunity to use local data. We have the local funding, and now we have a local seat at the table to really address this problem and develop solutions. And when we talk about the need for OD2A, as I was mentioning earlier, we're certainly not doing this work alone. This funding has allowed us to really be able to tap into partners that were already doing amazing work in the community to address this issue. And so one of our collaborators is the Houston Health Department. And we really look at this as an opportunity to really now be able to provide services not only within the city of Houston, but also services that really encompass the entire county to meet our unique needs. And so when we talk about more specifically the work that Harris County has been doing, really outside of OD2A funding, but also with the OD2A funding, we look at it as 3 C's: capacity building, collaborative planning, and programming, as well as community engagement. And so with the capacity building, we really started doing this work a number of years ago, but more specifically in 2017, when the current administration deemed the opioid epidemic as a public health emergency, our executive director really focused on us trying to really do targeted efforts on looking at the data, looking at what's happening in our community, looking at opportunities to tap into partnerships with groups that are already doing work in this area. And we stood up a multidisciplinary task force to really look at the landscape in Harris County. We also had funding from SAMHSA, which trickled down from the state to allow us to do coalition building work and focused on substance use and misuse prevention activities. We also have an opportunity to really to not only talk about prevention and of substance use and misuse in that coalition, but we also were able to really advocate for policy change, advocate for environmental change strategies, looking at ways to inform and educate the public about safe disposal methods for prescription drugs, and also ways to disseminate lock boxes and things like that throughout the community. We also deployed teams to go into various schools to really touch on issues that were impacting that are impacting students in our community. So really trying to increase the social and environmental changes from that standpoint as well. And when we talk about community engagement, we certainly view the healthcare system as a valued partner. And Dr. Kowalczyk certainly touched on some of these things that we are looking at to continue to partner with our healthcare entities, especially around the prescription drug monitoring program and our medication assistance training efforts. And also, lastly, we look at the community as our patient. We look at the general population here in Harris County as a way to really engage with them, and whether that's through print media, traditional media, social media, and outreach activities to really educate and bring about awareness. And so when we talk about our specific OD2A goals, they really are in line with our funder. This touches on the project aims that we have for OD2A, and it really, and I'll talk about them individually, but more broadly, they're really around awareness and how we understand what the opioid epidemic is in our community and how it's impacting our community. We're also looking at increasing streams of data and also looking at the specific types of surveillance data and using that information to really drive interventions on the prevention side. And we're also very actively doing cross-sector collaborations to really engage with entities that are really, like I was saying, already doing a work in this field, and really looking at opportunities to amplify that voice and to ensure that the message and interventions are delivered across the county. One of those collaborations that we'll talk a little bit about is our Texas Prescription Drug Monitoring Program. We're also looking at ways to continue to increase linkages to care. And then I'll also talk a little bit about the work that we're doing in collaboration with Baylor, with Dr. Kowalczyk, with our MAT program. And so when we talk a little bit more about the awareness and understanding how the opioid epidemic is impacting our community, more specifically, in 2019, the end of 2019 in November, more specifically, our department did a landmark study called the Harris Cares 2020, A Vision for Health in Harris County. And that an entire study is available on our website, and you can see all of our social media and our website is available at the bottom of all of our slides. But one of the things that that study really looks at specifically is chronic disease, and we also talk specifically about mental and behavioral health. And this is where a lot of this information comes from, where we talk about opioids as it relates to that particular study. But one of the things that we have found out is that drug overdose is the leading cause of accidental death in Harris County, and that opioids are involved in approximately half of substance use and misuse deaths. And again, I think we've mentioned this throughout the talk today, as well as the previous talks that have been on this platform, is that Houston and Harris County is a polysubstance sort of community, and it's certainly an issue that we're certainly paying a close attention to. When we look at the volume and the type of surveillance data, it's certainly all-encompassing. It's certainly not an exhaustive list, but we feel like this funding gives us an opportunity to tap into various streams of data, including emergency medical services data, syndromic data, which I'll touch a little bit on. The drug chemistry data, Dr. Kowalczyk did a fantastic job showing you some of the synthetic sort of behaviors that's happening in our community, but we certainly want to have a better idea about what that chemistry and what that makeup is of those substances in our community. We also have a partnership with the Harris County Institute of Forensic Sciences, or the medical examiners, to really have a broader understanding of the mortality and the deaths that are happening in our community, specifically those that are attributed to those deaths that are attributed and linked to opioids. We're also looking at substance use treatment provider data. And lastly, but certainly not least, we have an internal data warehouse at Harris County Public Health, where we're able to really have a repository of data that we can receive in, and also push that data out to really be able to really articulate what's happening in our community. Just wanted to show you an example of some of the syndromic data that we were able to look at, and this is data that's collected through the Essence platform, and this is the Syndromic Surveillance Consortium of Southeast Texas, and the host of that data is the Houston Health Department. But you can see here on the x-axis we're looking at time, and this is data for 2019, so the from January to December, and then on the y-axis we're looking at the number of emergency department visits, and this data is looking specifically at opioid overdose, and we put in opioid overdose by utilizing the CDC's query into this Essence database, and you can see in early 2019 where there were more emergency department visits because of opioid overdose. In 2020, you'll see the data looks a little different, and it's a little bit more to unpack here. And certainly on our x-axis again, you'll see the time, and it goes from the beginning of 2020 to current, where we're at now. And again, we're seeing a number of emergency department visits really toward this July timeframe, continuing to now. And so really just want to kind of to start off by just unpacking the fact that during March, we had our stay home, work safe order related to the COVID pandemic. And so I think it's really important. I think that we've already heard from the speakers, the previous speakers, to talk about the impact of the pandemic and what we're seeing anecdotally from our healthcare partners. But we're also seeing similar trends with the surveillance data, and we can see here where we had this phased reopening. Governor Abbott put in the phased reopening really at the early part of March. Then we had the second phase mid-March, and then this last phase of reopening in June, and then certainly in July we see really a sharp increase in opioid overdose syndromic data. And so we're seeing similar patterns with self-injury and self-harm, additional chronic disease entities as well. And so with a little bit more of our work as it relates to the cross-sector collaborations, just wanted to talk a little bit more about our partnership that we have with the University of Texas at Austin, the Center for Health Communications, and that's the Moody College. And a few years ago, Moody College collaborated with the state health department to really roll out a very robust education and marketing campaign around the Texas prescription monitoring program. As Dr. Kowalczyk said, this is now a required system that prescribers have to access before prescribing opioids. And so we really thought it was a great opportunity to utilize the funding from the CDC to really partner with UT Moody College to really expand on the work that they did with the state campaign, but really make a campaign that was very unique and specific to Harris County. And so what you see here are the really some of the final selections of the marketing that will be really deployed in our community. And so you have a first glance at it right here. And so this first depiction really sort of talks about every time you use the PMP, you take a stand to prevent opioid overdose in Harris County. And so in all of these, we really did, we queried and surveyed Harris County prescribers, and these were the ones that were the final selection. And this first one was, had about an 80% approval rating with our prescribers. And the second one received about the same amount, about 80% reception or likability with our prescribers. And it really says the biggest county in Texas can make a big change in the opioid epidemic. And then this last one was probably ranked the third in our prescriber group. But one thing I wanted to just really point out the fact is that this one says that checking the PMP every time means that you are checking your bias. And we think that that's such an important point to make, because not only is this a resource, this tool required, but it's really speaks to the fact that it should be something that no matter who's coming in front of you to get that opioid prescription, no matter what they look like, that you really that's something that needs to be checked every time, and it really speaks to the diversity and the equitable sort of approach that needs to be taken when utilizing the PMP. And we also wanted to just also talk a little bit about some of the partnerships that we have as it relates to linkage to care. And one of the programs that really highlights this really important role that we're playing as a convener with these multiple partners is our collaboration that we have with the Harris County Sheriff's Office. And that's really to expand their existing medication assistance treatment program. They're utilizing a couple of different programs. Well, one specific that they're using that we're partnering with them is their Vivitrol, or their long-acting extended treatment program for individuals that are in the county jail, and really they get that treatment upon release. And then they're able to continue those services with a healthcare partner in the community, but they're also receiving wraparound services with Houston Recovery Center for peer recovery services, as well as other community-based organizations to really be able to receive those very important and crucial wraparound services. And then we're also looking with partnerships with Patient Care Intervention Center to really continue to really look at how we can visualize that data, to look at all of the resources that those individuals are actually tapping into from a wraparound support standpoint. And then certainly one of the other partnerships that Dr. Kowalczyk really touched on as well is really our partnership that we have with Baylor College of Medicine. This is an opportunity to really continue those collaborations with our valued partners in our community, with our physicians, with our nurse practitioners, with our physician assistants, to really give them an opportunity to receive the training for the MAT waiver and certification. And this really is done in close partnership with Baylor to be able to lead those sessions, to really look at opportunities to address barriers that prescribers may also have in completing the requirements for the waiver, but also ushering them into opportunities to get them to the point of prescribing. And to really also be able to provide them with the technical assistance and the guidance to be able to use their waiver efficiently and effectively. Doctors for Change is also a partner that we're proud to collaborate with in this effort. They're leveraging their network of healthcare providers, residents, and students within Harris County, and we're also really relying on them to do a lot of the promotional activities as it relates to this work. They're certainly a key partner in us being able to obtain additional data for what these prescribers and what the audience is certainly looking for as it relates to this type of education. And so I think in relation to the time, I'll go ahead and stop here and go ahead and take any questions. And again, I thank you for the opportunity to just give you a little bit of information about the work that we're doing as it relates to opioid prevention.
Good job, Lise. Thank y'all for your time. So if you have questions, let's go to that Q&A and let's look at some of those questions. Of course, is going. One of the questions from Nancy, one of the questions is, could you provide examples of initiative clinical prevention? That's from Nancy.
I guess I can take it a little bit. I mean, I think one of the things that we're talking about with clinical prevention, we talked a little bit about the MAT waiver program that we're doing, and that's specifically targeting clinicians. And so we're offering them every quarter. We're able to offer that training, and we're utilizing Doctors for Change to help promote those activities. And again, that education is led by Dr. Kowalczyk, and also they're doing the follow-up sort of touch points with those attendees. And so I think that's one of the great examples of some of the clinical prevention activities that we're able to do. But Dr. Kowalczyk, I don't know if you have anything else that you wanted to
Yes. So thank you very much for teeing that up, Sherry. Yeah, we just had our last quarterly training last Friday. So just missed it, but we will have it again, likely December, because we are doing it quarterly. And it is free. It is the PCSS half and half course waiver. So I know that was mentioned at the prior speaker. So it is a national curriculum. It's 8-hour total training. 4 hours are done now via Zoom. And then the other 4 hours is completed afterwards online. And there's 4 hours of CME associated with that. So do look for that coming out in December. I think another one of the clinical prevention strategies or innovations that I've seen in my role as the opioid prescribing task force at Harris Health, within Harris Health, we now have naloxone on formulary within Harris Health, so it is covered, and we are developing standardized protocols so that when a provider does prescribe an opioid, for example, for an acute pain episode, they'll get prompted for naloxone to also be co-prescribed and dispensed for that patient. So those are 2 examples of some initiatives that are going on.
Looks like Ty. Many synthetic opioids come out to date, such as fentanyl or carfentanil. As far as he says, or she says, as far as I know, most of the synthetic opioids do not have antidotes such as naloxone. How do you take care of these patients who took opioid derivatives, particularly if they took counterfeit pill, including opioid derivatives? Interesting question.
Yeah, so actually naloxone does work on fentanyl and the other synthetics. It's just that they're much more potent. So usually you need more dosing and higher doses. And so most of the time when we're distributing, at least to the lay first responder community, or someone is getting dispensed naloxone through their provider, they usually get 1 or 2 doses. Someone that is getting naloxone because they're using street products or around or concerned about a loved one who's using street products, it is probably wise to try to get them a few more doses. So up to 3 or 4 doses may be required. And then it's also important to educate providers and first responders, whether they're lay first responders or they're professional first responders, that person who's overdosing, even if they're responding or minimally responding to intervention in the field, it's important to call 911 or for 911 to really take that person to the emergency center and not, even if they come to a little bit, not just leave them there, because they can go back into overdose when the naloxone wears off. Naloxone wears off in anywhere from 30 minutes to an hour and a half. And most opioids last in the system at least 2 hours for the very short acting. Most last about 4 to 6 hours. And so they can go back into overdose, or if they use on top of that, once they come out of overdose, really be in a worse situation. And then if you call 911 as you start your intervention with that person, even if your naloxone efforts aren't very successful, there's help on the way, and certainly providing artificial respirations for that person until they get to the hospital is really helpful and something that EMS can provide.
Okay, great. That was very thorough. I appreciate it. Ty, thank you for asking that question. Leanne, very interesting last name. I have a friend with the same last name. It is difficult to find adolescent and patient drug alcohol treatment in Houston and surrounding areas. She says she's found the Seneca and Odyssey House, but that is the only one that is specifically for addictions. Are there more that she's not aware of? Good. For adolescent and inpatient drug alcohol treatments in our area, are there more?
Yeah, so I haven't been updated on the park for a while, but the park has historically provided a full continuum of services to adolescents, from inpatient, residential, outpatient, aftercare support. Your adolescent does need to be resourced, so I don't think they take state-funded treatment. They have state-funded treatment beds available for adolescents, and I'm not sure about Medicaid or CHIP for them. Okay. And then I'm seeing in comments Center for Success and Independence. So thanks for chiming in there.
Oh, great. Is that over in the chat screen?
Mhm.
Wonderful. Look at that collaboration, y'all.
Yeah. And it also looks like unlimited visions.
Mhm. And then for outpatient, there's a PDAP, Palmer Drug Abuse Program, is an IOP program that's offered on sliding scale, kind of in the middle of town, over near the medical center.
If it's possible to write that over in the chat, all of those mentioned, that would be helpful, such as the park and the others, all in just one, so it's easy for them to copy and paste to help others with the adolescents. Glenda is asking, can they get a copy of the data provided today? I know in the years past, the email in would not be an issue. So if that's something you can do, will you share an email address or reshare actually your email address so they can get it? You can type it in the chat so they can email you. Be proactive. If there's any other questions, let's see here. I thought it was just, you guys, the data is interesting. Our next generation, we want to make sure that they're set up and their minds are great and strong and not being affected by the dependency of drugs and alcohol. So let's see, any other questions before we go into the last portion of today? All right. Well, thank y'all so much. We really appreciate your time today. I think it was a wonderful 45 minutes or hour or so of just information. So Dr. Sherry Oniogo and Dr. Alicia Ann Kowalchuk, thank you all so much. Good work.
Thanks for having us.
Absolutely. Thank you. That was great. They didn't have a dog or a cat in theirs, but that would have been pretty fun.
I had to come into work today, so I'm not at home. It's less fun. And I appreciate everyone on the conference today who's doing all this work in the community.
I love it. Yeah, absolutely. You guys are really, y'all are taking the information, the stats, the data, and going out and making effective change for the city of Houston and surrounding areas. So ditto on that. Great work. Thanks for reminding everybody that we appreciate you. We have a few more minutes left and that's it. And then we'll be done for today and we will come back tomorrow. Remember to get your TCOL and CE credits. You have to be on until the end of the broadcast today and tomorrow. We'll be back. You can use the same Zoom link. We're not done though. You can use the same Zoom link tomorrow. Whether you're standing over 45 or I-10, maybe we'll find a different background for tomorrow. But before we bring in our last person, I want to say thank you for joining us. We will see you tomorrow. Use the same Zoom link. This is going to be our last speaker, sharing just for a few minutes, just a brief few minutes. She's a licensed addiction specialist with mental wellness and behavioral health diversity authority with over 25 years experience working with children, adolescents, adults, and preserving family systems. Her name is Helena Washington. Due to her clinical rooting in mental health, her passion is working with holistic and collaborative approach to mental wellness, as well as educating communities, organizations, and corporations. She's very well educated. She obtained her bachelor degree in psychology and sociology from Grambling State University and her master's in counseling in 2001 from Bowling Green State University, with a focus on brain trauma, addiction, mental and emotional health, physical wellness, diversity, adolescent and women's concerns. She is the president-elect of the Houston chapter of Texas Association of Addiction Professionals Board, governed by the NAADAC, of the Houston Harris County Office of Drug Policy Committee, Board of Directors, Liberian Association of Greater Houston, and a member of the Kappa Alpha Sorority Incorporated. She's a dedicated mother of 3, a grandmother of 1, immigrated to the great United States of America from Liberia, West Africa as a child. We're so glad to have her. We're so thankful for you to share just for a few minutes as we wrap up here today. Ladies and gentlemen, please welcome with more credentials than we can write out, almost 26 like the alphabet. Please welcome Helena Washington.
Thank you, Johnny, for such a wonderful introduction. That is so funny.
Wait, are those all your degrees?
I actually have more credentials. I just don't put them down.
Goodness gracious, you look like Puff Daddy's house with all his records.
It's been a long journey, but thank you very much for that warm welcome. Just a moment of your time. I'd like to thank our wonderful sponsors, Houston Crackdown, Project Self-Control, Scholarship Program for Youth, Fort Bend Regional Council, the U.S. Department of Justice, the DEA, UT Health, Memorial Hermann Prevention and Recovery Center, which is now called Park Memorial Hermann, Houston chapter of TAP, which is also your CE provider, Prairie View A&M, the city's television channel, Houston TV, and Houston HIDA, and Houston Community College School of Health Sciences, the Coleman School of Health Sciences, and of course, the City of Houston. We want to thank all of our volunteers, all of those involved with putting on this wonderful conference. And I also would like you all to know you have a separate eval for today and another eval for tomorrow. They're not the same because not everyone is able to participate in both days. We hope that you're able to do both, but some may not be able to. So you have 2 evaluations. So make sure you complete today's evaluation, and tomorrow you will have an opportunity to complete tomorrow's evaluation after the wonderful presentations. One note that I want to point out, please be aware that it may take up to 3 weeks to receive your certificate. Just because we're in the process of evaluating, going through the evaluations, tabulating, because we're offering CEUs for all of the therapeutic licensure, the TCOL, as well as those who are in health sciences. So we will be providing CE credits for all of that, and there's 3 different portions to that. So just give us the 3 weeks. And if you have not heard from us or received your information, please email us after October 19th. If there's any questions, please let me know. In the question and answer, we will try to get back with you very timely. But let us know if there's any questions or concerns that you may have. Again, thank you for today. We appreciate it. We appreciate Johnny's phenomenal energy in keeping us engaged, and we thank the wonderful presenters. Thank you.
Ms. Washington, thank you. No, really, how many degrees do you have? I count just 5 in that glance, just out of curiosity.
I have 3 degrees, but I have a lot of credentials for various things throughout my journey.
Well, we appreciate you. I love it when there's excellence in the room and we hear from brilliant minds. I love it. I love it. And it's okay to share with people. It's okay. Some people are afraid. Tomorrow, we're going to have an action-packed day. We're excited to have you join us again. Just a couple of housekeeping announcements before we go. Part 2 tomorrow of the program, you can use the same link as we mentioned earlier. We're going to hear from Brian Middleton, the Fort Bend County District Attorney. We're also going to hear from the Houston Police Chief. Art Acevedo is going to join us tomorrow. Dash O'Gyan always has incredible information. We're going to hear from him and so many more. We're going to see you tomorrow morning. Make sure you're here with your cereal or popcorn, whatever you want, at 9 a.m. or a little before. We're excited to have you. Again, we're looking to have the 11th annual CDAD, Community Drug Awareness Day, be a hit. We want you to learn. We want you to go out and have effective change in our community. We don't want you just sitting there watching this to get your credits. There's no win in that. The win is you watching. The win is you taking notes, and the win is you going out and helping our community to become a drug-free. So thank you so much for the hard work you're doing. As a parent, thank you. We really appreciate you. We'll see you tomorrow morning at 9 a.m. Thanks for joining us. I need to go find a degree or 2 to hang up. I don't have, you know what? Helena, maybe you could fax me one. Who uses a fax machine? I just had perfect attendance, kindergarten through 12th. Have a great day. We'll see you tomorrow.
Bye-bye. Thank you.
That's awesome.